Good morning, I'm Dr. Andrea Ferrero, an orthopedic specialist with a particular interest in foot and ankle surgery. Today we are talking about cortisone, one of the most widely used drugs in orthopedics, but also one of the least appreciated by patients. First of all, it is important to say that there are different types of cortisone. Therefore, it is not correct to talk about cortisone as if there were only one type. Those we normally use for injections belong to the group of corticosteroids, which have a strong anti-inflammatory effect. In orthopedics, we often use cortisone when pain is related to an inflammatory process and when traditional treatments such as rest, ice, physiotherapy, or oral anti-inflammatory medications have not provided sufficient results. Cortisone can be administered by injection or taken systemically, for example orally. When cortisone is injected into a joint, the vast majority of the drug remains locally, and only a minimal part enters the bloodstream. Consequently, systemic side effects are usually minimal, except in diabetic patients, who may experience an increase in blood glucose levels. Many people are afraid of cortisone because of its side effects, but it is important to understand one thing: when used correctly, in the right place and at the right time, it is an extremely useful tool. In everyday medical practice, cortisone may be prescribed in the form of tablets or vials for injections. Oral cortisone is generally used in patients with rheumatic conditions who require a systemic effect from this powerful anti-inflammatory drug. Prolonged use of oral cortisone carries risks such as osteoporosis and avascular necrosis of the femoral head. Other typical side effects include weight gain, increased blood glucose and diabetes, increased blood pressure, immunosuppression with increased susceptibility to infections, insomnia, irritability, and depression. Cortisone may also cause eye problems such as cataracts or glaucoma, as well as gastrointestinal problems such as ulcers. Prolonged oral use of cortisone reduces the body's natural production of cortisol, which is produced by the adrenal glands located above the kidneys. For this reason, long-term therapy must always be tapered gradually to allow adrenal function to recover. As an orthopedist, I almost always perform localized treatments, using cortisone in liquid form for injections, usually into joints or in some cases around inflamed tendons. Cortisone is not a pure painkiller but a powerful anti-inflammatory drug. Its pain-relieving effect is due to its ability to rapidly reduce inflammation. Unlike common anti-inflammatory drugs, cortisone acts more deeply and for a longer duration. It crosses the cell membrane, binds to intracellular receptors, enters the cell nucleus, and blocks the production of inflammatory substances such as prostaglandins, leukotrienes, and cytokines. In other words, cortisone does not eliminate pain directly but removes the cause of pain, inflammation. By reducing inflammation, it also effectively decreases swelling and improves joint mobility. However, cortisone also has negative effects. 1. It reduces local immune defense. 2. It inhibits tissue healing. For these reasons, cortisone injections should be avoided shortly before surgery in the same area. For example, I do not recommend knee cortisone injections if a knee replacement is planned within 3 months. 3. Cortisone may weaken ligaments and tendons, especially when injections are repeated. As a general rule, no more than 3 injections should be performed within 12 months. There is one situation in which I always advise against cortisone injections, even a single one: the area around the Achilles tendon. Even one injection can significantly weaken the tendon and lead to spontaneous rupture. Cortisone injections are commonly used for joint pain, such as knee osteoarthritis, spinal conditions, or ankle arthritis. In the knee, pain is often associated with significant swelling, which can severely limit mobility. In such cases, arthrocentesis is performed before cortisone injection to aspirate excess joint fluid. The procedure involves a single needle insertion through which synovial fluid is first aspirated and then cortisone is injected without changing needles. Other conditions such as bursitis, epicondylitis, plantar fasciitis, and Morton's neuroma may also be treated with cortisone injections. There are few absolute contraindications to cortisone injections: suspected or confirmed infection, previous allergic reactions to cortisone, and any pathology involving the Achilles tendon. Caution is required in diabetic patients, as cortisone may increase blood glucose levels. Blood sugar should be monitored more closely on the day of injection. Personally, I avoid cortisone injections near tendons, especially repeated ones, due to the risk of tendon weakening. Before skin disinfection, the injection site must be accurately identified. This can be done manually or with imaging guidance such as ultrasound or X-rays, particularly for deep or small joints. Local anesthesia is not usually required for shoulder, ankle, knee, elbow, or plantar fascia injections but is essential for small joints of the hand and foot. After the injection, a sterile dressing is applied and can be removed at home. No more than 3 injections should be performed in the same area within 12 months. In severe inflammation, weekly injections may be considered but without exceeding 3 total. In osteoarthritis, once pain relief is achieved, further injections with hyaluronic acid or platelet-rich plasma, PRP, may be considered. These treatments do not damage the joint and can prolong the beneficial effects. On the day of injection, light activity is recommended. Avoid swimming pools, saunas, and baths for 24 hours, showers are allowed. Walking and driving are usually possible immediately. Temporary pain flare-ups may occur the following day, especially in the foot or hand, and usually resolve within a few days. If fever, redness, or systemic symptoms occur, medical attention should be sought immediately, as these may indicate infection. Skin discoloration around the injection site is a rare but possible side effect and may be permanent. Diabetic patients should always inform their doctor and monitor blood glucose more frequently after injection. Alternative treatments include hyaluronic acid and PRP injections. PRP is obtained from the patient's own blood and contains growth factors and stem cells. PRP can be safely used for tendon disorders without the negative effects of cortisone. Physiotherapy, including massage, techar therapy, and shockwave therapy, is often used alongside or instead of injections. In conclusion, cortisone is a very useful medication for managing many joint and soft tissue conditions. Its benefits, risks, and contraindications must be carefully evaluated by a physician based on the individual clinical situation. Thank you for your attention and for subscribing to this channel if you think my work could be useful.